currently in the process of applying to medical school for this upcoming cycle. For the past year, I have been fortunate enough to serve as the National Health Policy Chair for the American Medical Student Association. Today, we're going to have an interactive discussion with Dr. Carole Montgomery as we learn more about advanced care planning. And advanced care planning is just a topic that is really near and dear to my heart. Growing up, I had always heard of the term as a topic just because of my mother's role as a healthcare administrator as I was growing up. However, it wasn't until the winter of 2018, when my grandmother was diagnosed with pancreatic cancer, that this became a reality for me. In the 2 weeks following her diagnosis and her death, my family and I were thrusted into learning about how to devise a functioning advanced care plan. Thankfully, with the assistance of her care team and the support of our extended family members, we were able to devise a plan that allowed my grandmother to live the remainder of her days on her own terms and providing her with compassionate care centered around family caregivers. And that involved devising an in-home hospice care plan for her. So at this time, I'd love to take the opportunity to introduce our amazing speaker, Dr. Carole Montgomery. Dr. Carole Montgomery is the Executive Medical Director and Senior Faculty Consultant with Respecting Choices. She is a board-certified internal medicine physician with more than 20 years experience practicing hospital-based and post-acute medicine, and another 8 years in executive leadership positions. Before joining Respecting Choices, she provided executive leadership in a large integrated health system where she was responsible for development of population health management programs focused on integrating care across settings and specialties. In addition to standardizing clinical best practice, objectives included driving reliable patient engagement through standard engagement, shared decision-making, and advanced care planning. Dr. Montgomery earned her medical degree from Michigan State University College of Human Medicine. She completed her internship and internal medical residency at Butterworth Hospital in Grand Rapids, Michigan. She also earned her master's degree in health management and policy from the University of Michigan School of Public Health. So, welcome, Dr. Montgomery. And my first question that I would love to ask you is, how did you become involved or interested in advanced care planning?
Yeah, thank you, Courtney. And thanks to both Courtney and Maddie for helping to arrange this. I've really been looking forward to this. I love talking about the work and really see the value in helping. It's not too soon to start understanding about advanced care planning. So really what got me interested in the nature of advanced care planning is that during my practice as a hospitalist, there were many times where I was witness to patients and families who were really thrust into decision-making in a crisis, and reflected on the fact that some of them really seemed better prepared than others. And that preparation seemed to make a tremendous difference, because the families that were caught completely unprepared, never having discussed their hopes, fears, beliefs, and values about healthcare decisions, they ended up experiencing a grief that was amplified by uncertainty. And so I've come to think of that uncertainty as avoidable suffering, because through my personal and professional experiences like yours, Courtney, I now recognize that we in healthcare can do a better job of helping to prepare patients and families for the moment of decision making. And through that preparation, it eliminates some of that uncertainty and that avoidable suffering. So that when the time comes for decision making, whether it comes gradually or in a crisis, we can all rest assured that decision making is really grounded in what matters most to the patient, because we've asked them in advance. Knowing that we can make a difference, yet also witnessing how many times we aren't doing that and that avoidable suffering goes unaddressed, really created an unrest in me. And a need for me to find a way in my career to become more involved in spreading the skills and advocacy for advanced care planning as a standard of care for all adults. So that's kind of what brought me into this work.
That is amazing, amazing. So before we even get any further into this conversation, Dr. Montgomery, I would love to ask you, what can you give us as the working definition of advanced care planning?
Yeah, that's a really important place to start the conversation. As advanced care planning as a concept has sort of evolved over the years, there are a lot of different sort of mental paradigms out there of what people mean when they use the phrase advanced care planning. So in 2017, Rebecca Sidori, who's an amazing thought leader and researcher out of UCSF, brought together a group of experts, and using a Delphi panel arrived at a consensus definition that was then published. Let's see, I'll not hang up. I'll share my screen instead of hanging up. That was published in the Journal of Pain and Symptom Management in 2017. And what you'll see is really an elegant and simple one sentence definition for advanced care planning. But it's packed with a lot of meaning in each phrase, which I'll sort of unpack in the next few minutes. But advanced care planning is a process that supports adults at any stage, any age or stage of health in understanding and sharing their personal values, life goals, preferences regarding future medical care. And then they also created the accompanying goal statement, which says the goal of advanced care planning is to help ensure that people receive medical care that's consistent with their values, goals, and preferences during serious and chronic illness. And so having this consensus definition is really important, not only to guide our clinical practice, but it also helps center research around advanced care planning and policy initiatives. Recognizing though that this definition in one sentence is kind of abstract, and I'm a firm believer in a picture is worth 1,000 words. If I could share a story that might help to illustrate the it that we're talking about as advanced care planning, if that's okay.
Of course, of course.
And the story is that of my mom, who at the time this story begins was 83. She was experiencing progressive dementia. She was diagnosed with myelodysplastic syndrome with really that was manifest with pretty low platelet counts at the time of this event. Her platelet count was running a stable 5,000. So she was really at risk for spontaneous and catastrophic bleeding. And my dad was experiencing increased stress. He was non-medical, but he said, his words were, I know someday the bottom's going to fall out, and I don't know how this is all going to play out. And I don't know how I'm going to go about making a decision in that event. So I'll also admit that this was very early in my experience in even understanding what advanced care planning was, but I was an experienced hospital-based physician. I knew that I was really good at incorporating people's goals and values into making in the moment decisions. But it was really instructive to me to realize how hard it is to anticipate and plan for decisions that you don't even know what the decisions are going to be. I found myself saying, okay, what would we want to do if she has a GI bleed? What would we want to do if she has an intracranial bleed? What would we want to do if she breaks her hip? And you can't plan for the future that way. Yeah. You cannot anticipate every possible scenario. So fortunately, I was aware of an advanced care planning service in our health system at the time and made an appointment, and both my dad and I went in. My mom was not cognitively able to participate in the conversation at this point. And we had a very high quality facilitated advanced care planning conversation that allowed us to really gain clarity on what mattered most for her care, which my dad phrased as, we want to keep her free from being afraid, free from having things done to her that she wouldn't understand by people she didn't know. And that formed the goals upon which we knew we could face future decisions. And those goals were to avoid interventions that wouldn't improve her quality of life as she was currently experiencing it. Things like avoiding surgery, ICU. And so we had prepared for that future decision, even though we didn't know exactly what form that decision would take. And then the future became the present about a year later when my dad awoke to find my mom regaining consciousness on the bathroom floor. And it's important, I think, to pause here and recognize that despite advanced care planning and that preparation, the moment when healthcare decisions come to pass, oftentimes in a crisis, is a moment of vulnerability, even for the patient and family who've gone through the preparation, but also for the healthcare system, to make sure that those emergency providers who are involved in the care at that moment pause to ask if any prior planning has happened so that they can build from that. Fortunately, that did happen for us. The physician that met my dad in the ER that morning, before presenting any treatment options to him or making any recommendations, started by saying, "Tell me about your wife." And in doing so, really held up my dad as the source of precious information that was incredibly relevant to use in decision-making. And then she, as the physician, included the clinical information, and together they decided to get a head CT, which did show a significant intracranial bleed. But we were able to all be on the same page as a family because we had already known the guardrails, I guess, of how we would go about making a decision. And so it was self-evident that admission to hospice was the right answer for my mom. But most importantly, it avoided that agonizing middle of the night family conversation across 3 states with a non-medical family. I'm the only medical person in the family. I mean, it was just, the preparation was just incredible in, avoiding that suffering for our family, even though we were obviously horribly sad when my mom died.
Mm-hmm.
So hopefully that gives kind of a better image of not only what advanced care planning, how it can be done truly in advance of any specific decision, and the absolute benefit that it provides in doing so.
Honestly. And I just want to tell you, thank you, for sharing that moment of vulnerability with all of us here. It's definitely eye-opening to see, we don't often view our physicians as people outside of their jobs. Yep. And so, it's really great, especially for, persons who are currently practicing clinically, for those who are still in, like myself, in the, the working stages of getting to that goal. I'm just thinking about how this affects us as individuals just as much as it affects us from the other side when the white coat is on, So again, just thank you for that vulnerability.
Thank you. And that's a great point about, that we do wear 2 hats, one in our career and one as like people. And so at the end, we'll talk about what are next steps to learn more about advanced care planning. And, your point's a good one. One of the things will be, have you done your own advanced care planning?
Yes. Definitely. So I know that there is definitely a common perception that advanced care planning, generally it's only pertaining to end-of-life cares and end-of-life decision-making. But I noticed that the definition that we shared on the screen, it talks about supporting adults at any stage or any age of their health. So how do we make that connection real for us?
Yeah. So like I said, the consensus definition is deceptive in its simplicity, and what you picked up on was a nuance that's really critical. So that phrase, a process that supports adults at any age or stage of health, doesn't restrict this to end of life. So it's a broader concept of advanced care planning, and it means that the content or focus of an advanced care planning conversation should differ depending on where the person is in their life or illness trajectory. And so Respecting Choices has sort of conceptualized the range of types of advanced care planning conversations into really those appropriate for sort of 3 different, what I'll call patient populations or patient profiles. So the first is for people that are healthy or early in chronic disease. And for them, the circumstances where advanced care planning would play an important role is something like suffering a traumatic brain injury or a sudden neurologic event. And in that situation, it would be important for their healthcare agent to not only be named of who they want to make decisions for them, but also have that agent be prepared in terms of having had conversations before about what would their goals for care be if they had a traumatic brain injury that was life-altering. And so all young adults should have advanced care planning. I'll give you another short story. I've asked all 3 of my adult children to do their own advanced care planning. My oldest was able to do that, and we walked through it because she was pregnant and heading into a delivery, and that created enough angst in her that I seized the moment. My 26-year-old daughter, I haven't had as much luck with, but I've talked with her about the advantages and the importance. She did what I think is probably an age-appropriate thing and laughed it off and said, "Mom, nothing bad will ever happen to me." But a couple days after that, she called me from her car, really upset, having just seen a kid get hit on a motorcycle. And she said, "Mom, he's in the ditch. There's people around him. He's moving, but he's really messed up." And so I said, "Now, Jess, imagine he's probably going to have a lot of medical decisions made for him. He may not be able to participate. Do you think he talked with anybody about what his goals would be if he's not able to improve?"
Wow.
So those are examples of where it's really relevant to have done advanced care planning despite being young and healthy. So then the second sort of population or patient profile to think about are people who have progressive serious illness, but are engaged in perhaps aggressive treatment. So they're not end of life, but they, in those complex treatments, will be facing what I call micro decisions, or the insidious decision making of, well, we did that, now we got to do the next thing. They're at risk for delirium, for significant complications. And I remember we had a patient focus group, and I was struck. I wrote down this quote because this woman said, "I know that I'll have decisions to make in my future, but I don't know what they're likely to be. I'm trusting you all," and she pointed to us in healthcare, "to let me know what types of things I need to think about ahead of time so that I have time to make a good decision." And so proactive advanced care planning gives these individuals the space and time in the context of their disease and prognosis to reflect on what it means to live well, to think about if complications occurred, what circumstances would be unacceptable to them, and share that with others for use if they need to play a role in decision making. So an example to think about for that type of patient might be a middle-aged person heading into bone marrow transplant, hoping for a cure, reasonable to hope for a cure, but also at high risk for significant complications where they may be unable to participate in decision making. And then the third sort of prototype or patient population that we think about for advanced care planning are people who are much further along in their illness trajectory. So perhaps in their last 1 to 2 years of life, where the decisions they're likely to face are much more proximal, are more real to them, and are probably things that they've started to think about and maybe worry about. And so oftentimes they'll find it as a relief to be asked about it. So an example of that would be like my mom's story, right? We knew she had less than 1 to 2 years. And it ended up being a relief for our family to talk about it. So in those patients, it's very appropriate to refine the conversation to be more specific about decisions about CPR, ICU stay, what we traditionally think of when we think of end of life decision making. And so when thinking about those three patient populations, healthy, progressive illness, or the last years of life, it becomes clear that the content of those conversations really, it should be different because there are different needs that advanced care planning is playing. And so the company that I'm with, Respecting Choices, we've actually created competency-based educational courses that teach clinicians and non-clinicians how to have high quality advanced care planning conversations for each of those three patient populations, using conversation guides as sort of a roadmap for the content that's most appropriate for each of those situations. So also in that, you'll hear why this definition uses the word process. It's not, advanced care planning is not an event, it's a process that should evolve with the patient, because we know that from research, the patient's goals change and evolve as their illness progresses.
So just as we continue with advanced care planning, should it be something that's revisited over a period of time, or is it like, for example, I'm turning 25 this year.
Mhm.
So when I make my advanced care plan this year, is it always going to be the same one, or should I change it periodically?
That's a great question. And so we oftentimes think, there should be milestones. Like if we don't have a milestone in mind, how do you know when it needs to be revisited? We oftentimes will talk about the 5Ds as triggers for when a plan should be revisited. And this first one's going to sound weird, but death. And it's not the person's death, but death of perhaps a loved one. Oftentimes that loved one might have been their agent. And so you need to think about, do you need to select and prepare a different healthcare agent? Death could also just be death of a loved one, and that gives people different life experiences to have thought about and witnessed how things unfold. And so that might inform what they want for themselves differently. So divorce is the second one, again, for the reason that oftentimes a spouse is an agent. And if you get divorced, you might want to think about selecting a different healthcare agent as part of the advanced care planning process. The third D is disease. So if you have a new disease, new diagnosis, depending on the prognosis associated with that, it may be really appropriate. You might have that first healthy patient population now into the one with serious illness, where it's very appropriate to revisit the advanced care plan. And decade is a fourth D, which means any birthday that ends in a 0 is probably time to at least revisit and make sure that there's nothing that needs to be refined. And the fifth is decline. So if you're watching a loved one, a patient, sort of subsequently decline year over year, things may have changed enough to revisit. So death, divorce, disease, decade, and decline are sort of the triggers for revisiting an advanced care plan.
Okay. So how can physicians and student physicians introduce advanced care planning while maintaining their patients' autonomy? And maybe we can expand upon that to say, like, how do we also increase their confidence, especially for people who are healthier? How do we, engage in this kind of conversation with them?
Yeah. So I think how to engage people, especially those that are healthy and don't view themselves as appropriate for end of life conversations, is to make sure how we message advanced care planning as really an important part of health maintenance. It's a part of quality of care. It should be a standard of care. So introducing the conversations early and as a matter of routine sort of destigmatizes advanced care planning. I think regarding your question about patient autonomy, really a high quality ACP conversation is one way that we as physicians have of ensuring our patients' autonomy. Returning again to the consensus definition, the accompanying goal statement says that the goal of advanced care planning is to ensure that people receive medical care that's consistent with their values, goals, and preferences. In other words, they get to decide. And we should uphold that decision because that is the principle of autonomy. It's the right of competent adults to make an informed, uncoerced decision about their own medical care. And, while coercion is sort of a strong word, I think we do need to acknowledge that as physicians, we are in a position to strongly influence patients' decision-making through how we present and frame risk-benefit statistics, how we make recommendations. And we know from the many population health studies that look at preference sensitive care, it shows that there are more heart caths per capita done where there are more cardiologists. We know that there is more ICU care per capita given where there are more ICU beds. So while we may not think of our role as one of coercion, we do know that physicians can influence what decisions get made. And so, especially in serious illness, patients are at risk for having really significant medical recommendations made based on evidence-based guidelines, on protocols, and essentially based on what's the matter with them, rather than based on what matters most to them. And so really by providing adequate time and space to reflect on their personal life goals and values, we're helping patients in advance to stand ready to advocate and protect their autonomy.
Okay. I mean, it's just so important, and sometimes even unknowingly as clinicians, you can influence your your patient's decision, and as much as what they think, as much as what they're doing, just because it's the way that we speak to them. You know, we have to always be sure that we're engaging our patients in a way where we're not talking at them, but we're talking with them, and therefore that allows that conversation to happen organically. It allows us to connect with them in this way so that if they have any questions, if they want to know more about a certain topic, we're allowed to, you know, have that sort of banter, because especially when that white coat is on, they kind of see you as a position of power. And then they're kind of just saying, okay, well, whatever the doctor says, that's where I'm going to go with. But what happens when what the doctor says or whatever your care team says is not in line with your personal beliefs, you know? So it's always something that we constantly have to check ourselves as clinicians, just to figure out what it is that we're saying, what we're doing, and how we're seeing our patients react in real time to those things.
That's right. Remaining open to it. That's a great point.
So we all know, both from personal experience, that advanced care planning conversations can be extremely emotional. So what is the importance of practicing active listening with your patients?
Yeah. So actually, I can stop sharing the screen. Sorry. And maybe our faces will all be a little bit bigger. So active listening, as you point out, is really critical, really for any valuable communication, but especially in advanced care planning. So the paying attention, paraphrasing, awareness of nonverbal cues is really one of the most critical communication skills for high quality ACP. There are a couple other that I would like to elevate in the context of advanced care planning that are sort of foundational communication skills that are important for any conversation, but especially critical in advanced care planning. And the first is to explore the meaning of words and phrases. And what I mean by that is, don't assume just because a patient is using a common phrase that you both understand it to mean the same thing. So for example, if a patient says, I don't want to be kept alive if there's no hope for meaningful survival, you could think, wow, that's a powerful statement. I'll take that to heart. But then when you think about standing at the point of decision making, you realize that there's a lot of ambiguity in those terms. So for example, does a feeding tube count to that person as being kept alive? They said they wouldn't want to be kept alive if there was no hope. Well, at what % probability of survival would they say is no hope? Do they really mean 0? And they don't want to be kept alive unless there's meaningful survival. So what is meaningful to them? I know for me, I'm very clear on what is not meaningful survival for me, but I guarantee you it probably is different for everybody on this call. And so to learn the skills to really say, tell me what you mean by meaningful survival, and to be able to help them flesh that out in a way that is helpful, and then record it, help them record it in a way that it survives over time and across space, so that if and when it's needed, it is available to the providers at that time. So active listening, exploring the meaning of words and phrases. And then the third one, and we've kind of already touched on this, is remaining value neutral. And it is absolutely critical to really play a role of helping the patient's voice come to the surface. Ironically, it's also the one that's the hardest for the most experienced clinicians, because once you start listening for what I'll call the opposite of value neutral, I'll refer to as value laden. Once you start listening for value laden comments, you'll hear them everywhere in healthcare. It's really interesting. What it really requires to become value neutral is to acknowledge that through our own experiences, we develop biases about what patients should decide, what the right decision is. And we, unless we're aware of it, we will telegraph it through to the patient in how we phrase things. Sometimes it's super obvious. Like I remember a nurse calling me once. We were caring for a patient who was a Jehovah's Witness and had profound life-threatening anemia. And she called me and said, you need to come and talk this patient into getting blood. That's pretty overt. But sometimes it's more subtle. When we telegraph, for example, if we say somebody is non-compliant, that means they're not bending to my will. It completely eliminates the fact that they may have a reason for their decision. Or when we say, this patient has had a stroke, now they need a feeding tube. Well, the word need, do they really need it? That's sort of overlooking the fact that there's a decision to be made and that the patient or family needs to be included in that. So in another way of sort of being value laden is if we neglect, if we're proposing a specific treatment and we neglect to describe an alternative to that. Or if we say we could, and this happened to my husband, he was being offered an intervention and I said, what if we don't do that? He said, or we could do nothing. Well, there's no such thing as doing nothing, and so that telegraphed to me right there. The doctor was dead set on doing the intervention, to not even give time and space to talk through what it would look like if we didn't do it. So those are kinds of value neutral skill sets to develop. And the first way to develop them is through self-awareness. So, kind of going back to your question about maintaining patient autonomy, one of the benefits of advanced care planning is that it ultimately helps the patient find their voice and advocate for themselves before ever entering into decision-making where physicians might carry a bias about a particular decision.
So how can we make ourselves appear more trustworthy or increase that confidence amongst our patients when we're having these types of conversations?
Yeah.
Because you never really want to have these conversations with someone you don't feel like you trust or someone that you believe is actually going to listen to what your concerns are.
Yeah. So that's a great point. And I think we need to recognize and acknowledge and believe that there are significant numbers of patients who don't trust healthcare and don't trust clinicians. Oftentimes for lived experiences that, we've earned that distrust. And so it's a really important question, Courtnie, for us to reflect on of how can we become trustworthy? And so I think one of the ways is to really first explore and understand individuals and demonstrate that we care about them as people and not short circuit that by thinking of them as just patients, because to them, they're patients in this much of their life and they have a whole lot of personhood that we know nothing about if all we view them as our patients. And so to really show a curiosity to learn more about what matters most to them before ever entering into clinical decision-making and, pontificating about all the clinical knowledge that we have, but to really hold them up as partners in decision-making. And then, going through the whole advanced care planning process and helping somebody to stand ready to enter into decision-making, we can completely blow their trust then when we ignore all that at the time of a decision. So we really then earn our trustworthiness by honoring their goals and values that we took the time to learn.
Definitely. And especially for patients of color, I think that that's so important, learning to build that trust amongst your patients, because there is a history of distrust amongst persons of color, the American government, different healthcare systems, and just how they've seen history play out. And it's so important, that we learn to have these conversations and cultivate them organically, so that our patients feel comfortable enough to have these conversations with us.
That's right. And, having an ACP conversation, like I said, one of the things I worry about is, so we've gone to the extent of understanding and listening and documenting patient preferences. Is the health system really prepared to honor patient preferences when it comes to the time of a healthcare crisis? Do we have the muscle memory yet for the ER physician to start like the one did for my dad of saying, have you talked about this before? Or do they just start with, the ER protocol? And so that's something that we just have to continue to work toward.
It is. It's so important, so important. So I know that advanced care planning is extremely time intensive. It can involve really late phone calls with your family members. Sometimes it's just a really long day at the hospital as you guys try to work through that in real time. So how can we adjust for these things, or how can we make this a little bit better for ourselves?
Yeah. So I think there are many different strategies. The one I'll start with is having them in advance. I mean, it's advanced care planning, meaning in advance of a decision. So the further upstream, it will allow the conversation to take place over time. It doesn't have to be done in one, horrible 90-minute long session. It can be parsed out. You can make sure that you're including the right people. I think the other common misperception is that advanced care planning conversations can only be done by physicians. And in our experience at Respecting Choices, we have found that the vast majority of people that are going through our courses to become certified facilitators are not physicians. They are nurses, social workers, and chaplains. And we have demonstrated that they can very successfully have high quality ACP conversations. Now, physicians still play a role. The physician still needs to make sure that the patient is well aware of their diagnosis, their prognosis, because, prognosis obviously is going to impact what decisions a patient makes. And then honoring the plan is also the role of a physician. But even Atul Gawande in a conference acknowledged that Respecting Choices really has the best program to help non-physicians learn how to have standardized high quality conversations. And so that then helps with the time crunch and the skill set, frankly. The skill set of those different disciplines is very appropriate for discerning what matters most to people. And I guess in talking about this, it makes me realize that I've neglected to talk about really the evidence-based demonstrated outcomes and benefits of advanced care planning. I mean, you sort of heard some of them through the story that I told, but if I could just list off a couple ones that I think are really important for people to understand that, through research, there have been demonstrated benefits that include very high patient and family satisfaction, not just with the conversations, but overall hospital care in general is improved. There's measurable decrease in decisional conflict when it comes to the point of decision making for people. There have been some really fascinating studies that have measured the concordance, I'll say, between the patient and their advocate in the understanding of the patient's goals, and that agreed upon understanding of the patient's goals transcends time and course of illness. So it really helps to keep the conversation alive between the patient and the surrogate after it's started. There is one study that was really interesting. It looked at people after they've died and measured their grief response in surviving family members and found a significant reduction in complex grief responses with lower stress, anxiety, and depression in surviving family members. And then there has been shown an increased prevalence in advanced care planning for racially, ethnically, and culturally diverse communities, and an increased use of hospice and palliative care services near the end of life. So those are all things that have been demonstrated in studies. We've been working in this space for over 20 years, having worked with hundreds of different organizations. So to that, I would add what I'll call our experiential evidence, things that we haven't measured, but we hear time and time and time again. And that is just reassurance that clinician competency and confidence can be achieved through practice and education. And that we hear so frequently that there is less moral distress on the part of healthcare providers and clinicians who are caring for people at the end of life. And for seriously ill patients. I remember I had one physician in a course. He was a what I'll call a very interventional cardiologist. And he went through this and he said, you mean advanced care planning can help me differentiate what I should do from what I can do, which I thought was a really, really cool way to think of it. And this is what made me think of all this, Courtnie, was your question about time, is that we hear time and time again that programs that have really implemented advanced care planning as a standard of care, they spend less time on end of life decision-making in a crisis. They spend less time in late family meetings and in conflict resolution because they front-loaded it with conversations in advance when there's time. So, sorry, long answer to your question.
No, the longer answer was definitely needed. It was definitely necessary in this particular case. So as we start to wrap up this conversation, this amazing event is a partnership between your organization, Respecting Choices, between CTAC, between AMSA, for those who don't know, is the American Medical Student Association. And so as medical students, in our training, how do we build upon the important messages that this conversation has brought up for us? How do we engage with our future and, you know, the people that we meet on clinicals? How do we engage with them on these particular conversations?
Bringing it to life, right?
Yeah.
So I think the first thing would be to just develop the practice of critical thinking about how do patients go about making decisions? Because it's really different than the way clinicians go about decision making, which is all decision trees and protocols.
Yeah.
And so to really just start being with your patients in that new and different way, start listening with a different ear for how do we telegraph our biases about what we think a patient should do. And I think you'll start hearing it more, and start like paying attention to your residents and your attendings when you're on clinical rotations about how do they interact with patients about decision making and whose voice predominates that conversation. And oftentimes it's the physicians that talks and talks and talks and then waits to see if the patient agrees with them. And just think about, is that the way you want to practice? Or do you think that that's the right way to practice? And then I would encourage you to really devote time and prioritize developing your competence and confidence to engage in ACP conversations. Don't just try to wing it. Because that will not feel comfortable and is unlikely to be successful. Respecting choices, I mentioned before that we've developed competency-based, we call it certification courses for learning how to have these 3 different types of advanced care planning conversations for the 3 different patient populations. And I'll put up, registration is not yet open for these, but they are national courses. Anybody can sign up. Anybody on the call would be certainly eligible to sign up. They are virtual now, like everything else, Zoom. And the dates are here. You'll see the next steps, first steps, advanced steps. Those are the terms that we've used for the advanced care planning conversations. First steps is the healthy population. Next steps is the progressive illness. And then advanced steps is the ACP conversations geared for people in their last 1 to 2 years of life. So like I said, registration isn't yet open, but at the bottom of the slide, I am sharing my slide, right? You're seeing it?
Yes, yes.
Okay. At the bottom of the slide is our general information email. If you guys even just want to send an email saying you were part of this event and asking our staff to let you know when registration is open, rather than you guys having to check on our website, we're happy to do that as well. I also have some background conversations going on about special pricing for med students.
Okay, perfect.
I think the other thing is, I don't know how many people are aware of the organization called CAPC. It's the Center to Advance Palliative Care, and it's a membership organization. So if the healthcare organizations that you as students are working with are members of CAPC, then you would be able to access, there's a lot of really good information through CAPC, but Respecting Choices created a 3-module course called Building Physician Skills in Basic Advanced Care Planning. And that would be available to you at no charge through the CAPC website if your organization is a CAPC member.
Oh,
so those would be ways of building, making a professional commitment to yourselves to build those skills. And then pivoting to you not as future physicians, but as people would be the have you done your own advanced care planning? So that would be to think about, maybe not for you, but are you named as somebody's healthcare agent? I mean, now as future physicians, especially if you're in a non-medical family, you're probably the go-to person to be everybody's healthcare agent. And so make sure that you aren't just being tagged, but that you actually have a conversation so that if you have to fulfill that role, you really stand in a place where you understand what matters most in making decisions for that person. And then I guess the other thing to sort of explore would be to look at the advanced directives that are available in the state in which you're residing. And I guess, Maddie, were you, I had a couple up just to show as examples. And one thing that's interesting, knowing that each state has their own advanced directive legislation and the statutory requirements for what makes an advanced directive a legal document changes from state to state. I had always thought that that meant that you have a state form that you have to fill out, but that's not in fact the case. It's just that the advanced directive has to meet all the criteria that the state sets forth. And so there are different sources where you can go to access what meets the requirements for different states. So I'll share with you, I gotta move this thing.
We see it.
Yeah, the header is in the way there, so I can't, there we go. So this is a website hosted through the AARP where you can look at different advanced directive forms that have been created that meet the requirements for each state. So if I pull up Michigan, just because that's where I happen to live, this is what opens up. And so there are subtleties when you live in the world of advanced care planning that pop out at you when you look at forms like this. So I talked about how it's important to not frame this as end of life decisions because that's off-putting to people who are not at the end of their life. Yet this is very prominently sponsored by a hospice and palliative care organization and talks about end of life care. So I think that would make it hard to engage a healthy or person who's undergoing aggressive treatment with a hope of cure in completing this. But anyway, so there is 4 pages of preamble that are really important questions. Can I change my mind? How do I do this? What are the requirements? And then there is a or a fillable PDF. So that would be one. Then I mentioned Rebecca Sidori before, who's the researcher out of UCSF. She has created this prepareforyourcare.org, which is available for every state. It's available in, I know, at least English and Spanish, might be other languages. And it isn't just a form, it actually helps individuals walk through a process, including videos of what to think about. And so it really is a process that helps guide people. And I think this would be very appropriate for individuals who, are sort of in that first steps, healthy, early and chronic illness, make really robust discussions, and it helps individuals know how to talk about it with the person that they want to be their agent. So other things to think about when you're looking at what advanced directives, maybe even the healthcare organization that you're doing rotations in is, what about literacy levels? Because, this is medical and legal gobbledygook combined, sort of a collision of the worst of both for people that don't live in that world. And so to really be thoughtful about what is going to help a patient understand what the whole process is about.
Mm-hmm. Definitely. So Dr. Montgomery, just thank you so much. Before we close, I would just love to take this opportunity to open up the floor to anyone who has joined onto this meeting. So if you have any questions, you can send them directly to me via direct message in the chat group, or you can just post them generally within our chat. I have one here, and the person is asking, if a patient's family member requests not to fully disclose their diagnosis, how can you, or how would their care plan tend to differ in a case like that?
Of course, the first one has to be the hardest question, right? So I think first and foremost, we have to be patient advocates. And how to interpret why a family member is requesting the information not be disclosed is absolutely critical to knowing the right way to navigate that. If it is an absolute cultural norm for that patient and family, for the family to make the decisions and the person to defer all decision making, we need to understand that and to be able to respect that. I think another example is, what do I do when a patient just says, doctor, you make the decision, deferring the decision making to others. And I think it still matters for us to understand what the patient values. We can make the decision, but I still have to understand the concepts of their goals and values and beliefs in order to make a decision recommendation that's right for that person. I shouldn't do it based on what I would want if I were them, based on what I would want if it was my mom. You really have to still start with understanding the person.
Okay. A follow-up question is there any advice or recommendations about how to initiate conversations about advanced care planning with people who are hesitant to have them?
Yep.
The person is thinking about this in the context of their family, but they also believe that this applies to us in general as future care providers and current ones as well.
Yep. So this is a great place to use the skill set of exploring. Exploration just is really important. So explore, what do you think advanced care planning is? What does advanced care planning mean to you? What do you understand it to be? Because oftentimes you'll hear misconceptions. Like my daughter, I'm not going to die tomorrow. Why do I need to, and so to understand the hesitancy and to explore it a little bit can oftentimes be really insightful. I think one of the other reasons to do your own advanced care planning is because then you can be honest with your patients and say, it's normal. It's part of good healthcare. Even I've done it. And that can help to destigmatize it. So that's a great conversation starter. Another is to make sure that they feel confident that they matter, their voice matters. And advanced care planning helps their voice be heard, even if they become unable to participate in decision making. I think a lot of times the other really helpful way, especially with family members, and I'll confess I did this, I think, with my dad, is guilt them into it and say, don't put me in that position. If something happens to you, everybody's going to look to me, and that's not fair to me. You need to be able, I need to know what you would want. I need to have this conversation with you so that I can effectively speak for you and not just be left wondering if I did the right thing or not. So I think that's the other thing, is to describe it even to your patients as a gift to their families.
Definitely. I mean, and it's so important to plan because it's, even though we try not to frame advanced care planning in the terms of end of life, that's generally what people think of. And in the context, if you plan a funeral 10 years in advance and you go to the funeral home as opposed to waiting till when the person has already passed away. That can literally save you $10,000, literally, especially in Florida. That's the difference between, you know, half of your life savings and, you know, just having a conversation. So I think the earlier that we have these conversations, the better, the more we are able to connect with our patients, we're able to connect with our family members. And as you showed us, there is evidence-based experiments as well as research that shows that like it just takes the stress out of everything, and it helps to, you know, just make the situation more easier to deal with for everyone
Right,
who's
right.
involved.
It doesn't remove the grief, but it certainly makes it, it removes the uncertainty of, did I make the right decision?
Yes, definitely. Thank you so much. So we are about at time, unless anyone else has any more questions. You know, we'd love to hear them, but thank you, Dr. Montgomery. Thank you to the members of CTAC, to the members of AMSA who are on our leadership boards who have helped to make this conversation happen. I'm so happy and grateful and honored to have had the opportunity to speak with you, Dr. Montgomery, about this particular thing. And we just look forward to having more conversations, to engaging in more partnerships, to continuing to have this conversation, to open it up so that more people learn about this and that we can get more people to do the advanced care plans as time progresses.
Thank you very much. I've really enjoyed it.